I want to thank you all for coming here and listen to the presentation on sleep and aging, and we are going to get started. So I will go ahead and get started, and we'll discuss the changes which occur in the sleep with aging. And I will also go over some of the primary sleep disorders in older adults, and we'll focus on insomnia because that's a very common complaint, and we'll also focus on sleep apnea. Now there's a lot of data that is emerging that is linking the sleep disorders with dementias and cognitive impairment. So towards the end, I will discuss that. So this slide just goes over how the population, and especially the older population, is increasing. And you could see here that by the year 2030, about 1/5 of our population will be over 65 and older. So this population is increasing. We'll be seeing more and more of older patients. So we need to know what happens to their sleep when they age. And sleep is an important part in one's life. We spend 1/3 of our life sleeping. So let's see what happens when we age. So this is based upon a large meta-analysis. What we say is a lot of studies were looked at, and lots of sleep studies were done in different age groups, and you can see in the bottom, these are the different age groups. This is age, and this is increasing age. This is the total sleep time. These are just different stages of sleep which are measured by those EEG leads, which are done by the sleep studies. You know, slow wave sleep, this SWS means the deep sleep. REM sleep, which is the dream sleep. So you could see that the total sleep time, as you could see as compared to here, with increasing aging population, decreases. People spend a lot of time awake when they go to sleep. There's a decrease in the dream sleep with increasing age. There's a decrease in the deeper sleep with increasing age. So in general, older people sleep less, they experience more fragmented sleep, and spend less time in the deep sleep, the stage 3 sleep, that slow wave sleep that I told you. As you can see, there's a significant decline here. And the dream sleep is also decreased than younger people. And these are some of the physiological changes which occur with normal aging. So this slide goes over the arousals. There's many awakenings, again with increasing age. And here is arousals. That when we are aging, these mini arousals, and these are 3-second arousals, also increase with increasing age. Now circadian rhythm changes. So what happens to our normal tendency to fall asleep, those times? So generally speaking, this may look complicated, and you can just hear me out. That generally speaking, older people tend to go to bed early and arise from bed early than the younger adults. And this happens because of the normal physiological changes that occurs with increasing age. And some of the changes are timing of the core body temperature, which regulates what time we go to bed and what time we wake up. The melatonin, which regulates what time we go to bed and what time we wake up. These are all kind of pushed to an earlier hour, what we say advanced sleep phase syndrome, going to bed early and wake up early. So older people may not be able to enjoy the evening activities as compared to younger adults. And these are some of the physiological changes, the natural changes that would occur with increasing age in older adults. This slide again just shows that in an older individual, the core body temperature, which regulates what time we would go to bed and what time we would wake up, that amplitude is decreased, and thereby these people are just sleeping earlier and waking up earlier. So let's look at some of the common sleep disorders, the prevalence of these common sleep disorders. And you can see here, these are all adults and these are the elderly. And the prevalence is significantly higher in older people as compared to the younger people. So the insomnia, which is difficulty sleeping, is prevalent in 1 in 2 older adults. Sleep apnea prevalence increases highly as compared to the younger person. The restless leg syndrome, very highly prevalent in aging population. REM sleep behavior disorder, in which people act out their dreams, is common in elderly patients as well. And you can see the comparison right here, how common these disorders are in older patients as compared to the younger patients. So let's talk about insomnia. As I said, the prevalence of insomnia. What is insomnia? Difficulty falling asleep, or difficulty maintaining sleep, or waking up early in the morning, associated with some kind of a consequence. Either you feel tired, you're not able to concentrate, and that's called insomnia, despite given an adequate opportunity to sleep. And the prevalence of insomnia increases with increasing age. Somebody who is 70 years of age is twice as likely to have this difficulty sleeping as compared to somebody who's 20 years of age. Now, a lot of conditions can affect sleep in older adults, right? Poor sleep habits play a big role. It sounds simple, but plays a big role. Consuming caffeine 4 to 6 hours before the bedtime. Consuming alcohol before the bedtime can really disrupt sleep. Irregular sleep-wake patterns, I think it plays a crucial role, and I tell all my patients, be it younger or be it older patients, to have a consistent sleep-wake pattern. And it is very important, especially in older individuals, especially in retired individuals, where they have the flexibility to sleep at whatever times they want to, but that can really affect the circadian rhythm. So it's very important to maintain the same sleep-wake patterns. Medical illnesses, and I'll talk about that in a second. Medications, a lot of medications can affect sleep. Steroid medications, heart medications, beta blockers, they can all affect sleep. Psychological distress or psychiatric disorders, which are very common in older patients. Depression is common in older adults. And we know that people who are depressed are more likely to have insomnia. And sleep disorders itself can cause insomnia. Sleep disorders that I told you, the sleep apnea, restless leg syndrome can cause insomnia. These people have difficulty falling asleep, difficulty maintaining sleep because the legs don't let them sleep. They are bothersome. Restless legs, which is an urge to move the legs, more so in the nighttime than during the daytime. It can be easily correctable, by the way. Many medical conditions, as I said, disturb the sleep, right? So, and older patients are more likely to have medical conditions, arthritis, osteoarthritis, the pains, the discomfort that won't let people sleep. The neuropathy, the peripheral neuropathy, the tingling sensation in their extremities, in their legs that won't let you sleep. The heart conditions, coronary heart disease or congestive heart failure, which causes shortness of breath while lying down, would not let a person sleep. Headaches and so forth. And these are more common in older people. So this slide just tells us how all these are playing with each other in causing this difficulty sleeping. As I said, there are things that occur with normal aging. Right, these people, with normal aging, the deep sleep decreases, the dream sleep decreases. Older people tend to sleep early, wake up early. The things that occur with normal aging, that is loss of health status. The primary sleep disorders like sleep apnea, restless leg syndrome, are more common in older people. And then older people may also have some other psychosocial factors which may predispose them to have difficulty sleeping, such as loneliness and bereavement and retirement and so forth. So all these play with each other and can cause difficulty sleeping. So there are numerous studies which have looked at the consequences of poor sleep, in particular in elderly. So poor sleep in elderly is also associated with increased risk of falls, increased risk of shorter survival, and pain, increased incidence of pain. Poor sleep is people who sleep poorly are more likely to experience pain, difficulty in sustaining attention. They may not be able to have a good concentration. They may not be able to accomplish their daily activities. So all these could be consequences of poor sleep in elderly. So treatment of insomnia in older adults, and I started with something called as cognitive behavioral therapy for insomnia. Now there are two treatments for insomnia. One is medications, right? There are medications for insomnia. There are all kinds of medications, such as Ambien, Lunesta, and so forth. There is a non-medication modality for treatment of insomnia, what we say cognitive behavioral therapy for insomnia, in which a person would go over your sleeping habits and would provide you with good coping skills as to how to sleep well. And it has been shown to be safe, it has been shown to be effective, and this slide is just showing you one study which looked at Alzheimer's disease patients and showed that Alzheimer's disease patients' sleep quality was improved by this cognitive behavioral therapy for insomnia, not only in the patients but also in the caregivers. There are other studies in the medical field which have shown that cognitive behavioral therapy for insomnia can improve the insomnia in people who also have other medical conditions that I spoke about. And of course, one always has to try to treat the underlying disorder. For instance, if we think that insomnia is coming from depression, underlying depression, that needs to be addressed, and perhaps addressing the depression would improve the insomnia as well. So this slide just tells you some of the risks that are associated with hypnotics, these sleeping pills. There are numerous studies which have been done, and this particular study showed that when a person uses hypnotics, there's a high risk of falls. So in this study, they showed that the risk of fall is about 30 times in a person who was using these sleeping pills, even after they took into account some of the other things that can lead to falls. So these sleeping pills or hypnotics can impair posture. It can reduce the reaction time, can reduce the coordination, and also the protective responses during falls. So this statement I took from the Center of Disease Control and showed that older individuals, about 1/3 of them who went to the emergency room because of their adverse responses to sedatives were hospitalized, compared to only 13% of the younger individuals. So which means that you have to be even more careful in giving these pills to older people given the side effects profiles. Now having said that, that doesn't mean that that cannot be prescribed. It just means that you have to be extra cautious in older patients because of the side effect profiles that these medications are associated with. The study compared head-to-head the cognitive behavioral therapy for insomnia and the sleeping pill, which is used in UK, and showed that cognitive behavioral therapy for insomnia was superior to this medication in improving the sleep efficiency, and this was based on the sleep studies, and also when people reported it in their sleep diaries, and you could see that cognitive behavioral therapy of insomnia has higher bars as compared to the medications. So indicating, yes, this is effective, but it may not be available everywhere, but it's an effective mode of treatment for treating insomnia in older adults. So that was insomnia, right? Difficulty sleeping, which could be due to different reasons in older adults. And then once you look at the underlying cause, medications can be considered, but safely. And cognitive behavioral therapy for insomnia should also be considered. Now I'm going to talk about sleep apnea. Now this slide goes over the prevalence of sleep apnea. As I mentioned here, in the bottom here is the age. This is the prevalence. It increases with increasing age, like insomnia. So sleep apnea also increases with increasing age, and I'll tell you why. There are numerous reasons that a person can have sleep apnea. One is the body weight. So with increasing age, a person is more likely to gain weight and predisposed to have sleep apnea. There are some other changes which occur in the airway. The airway becomes more collapsible. It becomes more floppier with increasing age, so more tendency to collapse. So you know what sleep apnea is, right? It's a condition when people have these repetitive episodes when the airway is collapsing during the sleep. So that's called sleep apnea, and it is associated with excessive daytime sleepiness, snoring, and a lot of other heart problems. So the airway becomes more floppier with increasing age. As I said, that deep sleep is decreased with increasing age, and deep sleep is considered to be protective for sleep apnea. So because of the loss of deep sleep, that also predisposes an older individual to have sleep apnea. So this slide just kind of distinguishes how people may present differently in the older age group as compared to the younger age group when they present to a clinician or a physician with the sleep apnea. So in younger people, males are more likely to have sleep apnea, whereas in older people, you know, it's equal in both men and women. The risk of sleep apnea is equal in men and women in older people, and that's because of the hormonal changes, the menopausal changes that occur in the women, which predisposes them to have sleep apnea, and the risk becomes the same. Now we always say, yes, obesity is very important, right? Extra weight is important in sleep apnea. Yes, it is important, but it is more important in younger patients as compared to the older patients. Now, the witnessed apnea, which means somebody is noticing having pauses in breathing, is a very sensitive sign for sleep apnea. Now, that may be present in younger patients, but in older patients it may or may not be present. Even the snoring. The absence of snoring does not exclude sleep apnea in older person. They may not have snoring. And as I said, the prevalence is high in older patients, and lots of studies have looked into it. And in regards to consequences of sleep apnea, I already mentioned that sleep apnea can be associated with lots of heart consequences, high blood pressure, and even nocturia, the tendency to go to the bathroom in the nighttime, actually could be a symptom of sleep apnea. And the reason is when you're having sleep apnea, these repetitive episodes when the airway is closing, it can cause some stress in the heart, and the heart releases this hormone which causes somebody to pee more during the night, and that can be a symptom of sleep apnea. I see it very commonly in older patients. We treat their sleep apnea and nocturia gets better. So in regards to the treatment, CPAP still remains a treatment of choice. CPAP, which is a continuous positive airway pressure. There are other treatment options for sleep apnea as well, but CPAP is a treatment of choice where the idea is that it's going to push in the air and splint open the airway. Older people may require a little bit less pressure than younger patients, but still CPAP is the treatment of choice. And older people do tend to tolerate CPAP equal as compared to the younger patients. So is sleep apnea bad in older patient? Yes, it's bad. It's bad. When, especially if it is associated with excessive daytime sleepiness. It can cause decrease in quality of life, and I said that before. Cognitive impairment, and I'll go over that in a little bit, how sleep apnea is linked with cognitive impairment. Increased risk of nocturia, going to the bathroom while sleeping. Increased risk of hypertension and cardiovascular disease. So yes, it can be bad, even in older patients. So when should we treat sleep apnea in an older patient? When we think somebody has hypertension, when we think somebody is having cognitive dysfunction or dementia, somebody is having symptoms of nocturia, think about it. Could that be coming from sleep apnea? Yes, there are obvious reasons in older patients, sometimes prostate reasons and so forth. But again, sleep apnea should not be discounted for somebody has heart problems, somebody has moderate or severe sleep apnea. It should be treated. And if we think the symptoms are coming from sleep apnea, and symptoms such as snoring, stopping breathing, impaired concentration, excessive daytime sleepiness, it will be treated no matter what the age of the patient is. Does CPAP do anything in older patients? Yes, we have lots of studies to show that. It improves the sleep. It helps people sleep. It improves the daytime sleepiness. It improves the symptoms of sleep apnea, such as snoring and gasping for air. And it improves the motor speed as well. This study just shows that CPAP was able to reduce the nocturia events in the patient who was having significant nocturia and patient who had severe obstructive sleep apnea. So we saw sleep apnea, yes, it's common in older patients, and it's common due to different reasons, because the airway becomes more floppy, it becomes more collapsible, the increasing weight, the deep sleep decreases. All this leads to more predisposition in older people. They may not present similarly as younger patients. They may not necessarily have loud snoring or stopping breathing episodes, but they may have nocturia, and one should pay attention to that. And CPAP can definitely help in older patients. And there are other options for treatment for sleep apnea as well, which could be discussed with your clinicians. Now I'm going to switch gears and talk about sleep and dementia, because there's a lot of medical literature which is coming out for this. Now sleep apnea, as I said, is associated with cognitive impairment. There are lots of studies which have been done. This was one big study which was published in 2011. And it showed that patients who were spending a lot of time with lower oxygen levels had more risk of the development of dementia as compared to people who did not have oxygen levels going down or who did not have sleep apnea. So this study showed that sleep apnea could be a risk factor for the white matter changes in older population, and they took into account the severity of sleep apnea. As you can see, there were people who did not have sleep apnea. These were people with mild sleep apnea. These are people with moderate to severe sleep apnea. And this is based upon what we say AHI, which is calculated with the sleep study. What it means is apnea-hypopnea index, and what it means is how many times these episodes of stopping or decreased breathing are occurring in an hour on an average. We say 5 to 15 is mild, 15 to 30 is moderate, and over 30 is severe. And found that people who had bad sleep apnea, moderate or severe sleep apnea, are more likely to have these changes in the brain as compared to people who did not have obstructive sleep apnea. Again, a similar study showed the same thing, that sleep apnea is linked with the white matter brain damage in these individuals. Another study which looked at oxygen levels, that people whose oxygen levels were going down, and when they performed these biopsies of these patients, and these patients when they died, they found that people who had lower oxygen levels during the sleep studies were more likely to have these microinfarcts in their brain. This was a study which was just published last year and showed that people who had sleep apnea or sleep disordered breathing as compared to patients who did not have sleep disordered breathing were more likely to develop cognitive decline at an earlier age. As you can see here on the bottom, age of onset. These people did not have sleep apnea and these people had sleep apnea. So people who did not have sleep apnea, they did not develop the dementias until later age, whereas people who had sleep apnea had dementia at an earlier age. Few studies showed that the white matter changes, which are considered to be bad in the brain, improved with the treatment of CPAP, and there was a study which looked at a 1 year with the CPAP and showed that with that there was a reversal of these white matter changes which occurs due to sleep apnea. The study showed that actually patients who were using CPAP on a more regular basis and with a longer hours, their memory was better as compared to patients who were using CPAP for less amount of hours. Now, a more recent evidence is suggesting that patients who are sleeping less, especially patients who are sleeping less than 6 hours, are more likely to have the amyloid burden, and this is seen in patients who have Alzheimer's disease. However, that doesn't mean that if you sleep less, you're going to develop Alzheimer's, but they did see that patients who were sleeping less had more likelihood of having these bad kind of proteins in the brain, which are seen in those who have Alzheimer's disease. So the concept is that perhaps when we sleep, all the bad stuff flushes out from the brain. It helps in clearing the metabolites when we sleep, and that might be playing in a role somewhere in a role why people who have dementia had these strong associations when people were sleeping less. There are also studies which shows that when people sleep solid or when they're able to sleep, having a more consolidated sleep, the Alzheimer's disease incident was decreased. As I said, sleep also helps clear this bad peptide, which is a beta peptide, which is seen in patients who have Alzheimer's disease when they looked into the mouse models when they did sleep. When they did the studies in the mice model, that when these mice were sleeping, the beta peptide was flushing out. Now, what are some of the mechanisms that might be playing in a role in causing sleep disturbances in dementia patients? Now, it could be that these lesions are occurring in those pathways in the brain. And some of the medical and psychiatric conditions that they may be associated with can also cause sleep disturbances in dementia. The medications that are given in dementia can have their own side effects and can disturb sleep, in fact. And some of the clinical features that these dementias come with can also disrupt the sleep, and nocturia and excessive motor activity, which could be seen in certain dementias, can disrupt the sleep as well. So in Alzheimer's disease, there is a theory that perhaps there is a bidirectional relationship, that both are playing a role in causing each or the other. So in obstructive sleep apnea, there is a fragmented sleep. The sleep is fragmented because you're having these repetitive events of stopping or decreased breathing. And as I said, this fragmented sleep can cause excessive beta amyloid, the bad protein which is seen in Alzheimer's, and can lead to this amyloid deposition, can increase the susceptibility for Alzheimer's disease. Same thing happens with obstructive sleep apnea. Oxygen levels also goes down, The inflammation in the body, the bad inflammatory markers are also increased, and they perhaps are also playing a role in increasing the susceptibility for the Alzheimer's disease. And when somebody has fragmented sleep, they may also have decreased cognition and physical activity, and that can cause fragmented sleep as well. So all this play a role with each other and have a bi-directional relationship, which means relationship in both the directions. So some of the sleep changes that can occur in dementias and in Alzheimer's, for instance, there are changes in the sleep-wake rhythm, and that may be associated with the severity of dementia. These people tend to wake up a lot. They may have decreased slow-wave sleep. They may sleep less. They may have decreased dream sleep. They may take a lot of time to fall asleep. And then there may be changes in the circadian rhythm, which is related again to the severity of sleep apnea, and that might be because of where these proteins are being deposited in the brain that may change, that may be in the pathways of those circadian rhythms. So Parkinson's, which is a different entity, there's a lot of insomnia seen here, which is both difficulty falling asleep as well as difficulty maintaining sleep. Restless leg syndrome that I told you about, which is an urge to move the legs, is very common in those who have Parkinson's disease. And then they may have, as I said, insomnia, they have stiffness, they have symptoms associated with Parkinson's, myoclonus, and so forth, which itself can disrupt the sleep. The Parkinson's patients may also have something called as a REM sleep behavior disorder that I alluded to a little earlier in the presentation. REM sleep behavior disorder is when people tend to act out their dreams, and the idea is that one could injure themselves or their bed partners, so having safety measures in the bedroom are of paramount importance, although there are medications which could be given as well. But this REM sleep behavior disorder is very common in Parkinson's disease patients. I already discussed about some of the changes which occurs in the circadian rhythm. The circadian rhythm means when you go to bed, when you wake up. It can all happen, and this is regulated, as I said, by these pathways in the brain. This nucleus regulates that. That's called suprachiasmatic nucleus, and if something is happening in that area, that can lead changes to the circadian rhythm. So this kind of just shows that there are circuits in the brain which regulates the wake promotion, which regulates non-dream sleep promotion, dream sleep promotion. There's a dream, non-dream switch. So if anything is happening in this pathway, that can certainly affect difficulty sleeping or dream sleep or non-dream sleep and so forth. So we discussed a little bit about Alzheimer's disease. I'm going to also discuss some other dementias as well. So in summary, for the Alzheimer's disease, we know that sleep problems are associated with early Alzheimer's disease pathology, but we don't know if sleep problems can trigger Alzheimer's disease pathology or make it faster. We still need to know more about it. We still need to do lots of studies about it, but sleep plays an important role. This is something called as synucleinopathies, when there's an aggregation of this abnormal protein, alpha-synucleins. It can be seen again in Parkinson's disease, dementia with Lewy bodies, or multiple systemic atrophy. A lot of sleep changes can occur in these patients. The REM sleep behavior disorder that I alluded to, acting out of dreams, is very, very common in these patients. Parkinson's disease, dementia with Lewy body, and multiple system atrophy, and that this goes over the prevalence here. You can see it's so very common, like 60 to 90% in those who have multiple system atrophy, 68 to 80% in dementias with Lewy body, and 15 to 65% in Parkinson's disease. And if somebody has REM sleep behavior disorders, there are some studies which show that one could develop some kind of dementia or neurodegenerative disease after they've been found they have REM sleep behavior disorders. And although it can occur after many years, even decade after you've been diagnosed with REM sleep behavior disorder, but there are studies which show that you could have neurodegenerative disease after you've been diagnosed with REM sleep behavior disorder. As I said, dementia with Lewy body REM sleep behavior disorder is very common, and I'll just limit it to that. Multiple system atrophy is associated with reduced and fragmented sleep, excessive daytime sleepiness, sleep apnea, and then they may also have nocturnal stridor, which means difficulty sleeping. So in these synaptopathies that I told you, the changes occur because, as said, there may be changes which are occurring in those pathways, which can cause REM sleep behavior disorders or sleep apnea. The fragmentation of the sleep can arise from the symptoms that they are associated with, some stiffness or dyskinesia, stridor and obstruction. So management, especially in this group of patients, is mostly conservatively for the sleep disorders because, again, as I said, the medications may actually can worsen the cognition. So you're making some of the symptoms worse and can cause behavioral changes. So for insomnia, as I said, is very common, and it can disrupt the caregivers of people who are taking care of these patients. But again, one should be very cautious for the medications. But having said that, you could use it, but with caution. So very importantly, maintain a good sleep hygiene, and I will discuss about that in a little bit. Maybe be more active during the daytime, so that don't take naps, because taking naps can cause insomnia. Some medications that could be tried is melatonin, trazodone could be considered, and if there are really delusions or agitation, some medications such as quetiapine can be considered, but again, these are given by the physicians with close monitoring, close follow-up with them. The REM sleep behavior disorder, as I said, the safety measures are very important in this situation, especially for the patient as well as the bed partners. Perhaps putting the mattress on the floor, padding the furniture, making sure that there are no dangerous objects around them is very important. Melatonin can sometimes be given in the patients who have REM sleep behavior disorder. Clonazepam, what we say Klonopin, can be given. It does work very well for REM sleep behavior disorder, but you have to keep in mind that it can exaggerate the cognitive issues. It's associated with daytime sleepiness and drowsiness and so forth. So, and it can also make sleep apnea worse because it's a benzodiazepine and maybe quetiapine, but more commonly used medications are Klonopin and melatonin for REM sleep behavior disorder. So hallucinations may be present, but if that's the case, one should avoid new medications and try to adjust the medications that they're on, and that should be done, of course, in conjunction with your physician. Adjust the dopaminergic agents, adjust the medications, the anticholinesterase, and so forth. Sometimes some medications can be avoided that are causing hallucinations and maybe could be discontinued, and you could talk to your doctor about it. Certain medication which might be playing in a role in causing hallucinations. So in cognitive complaints, the sleep screen is very important. So one should certainly evaluate the patients with mild cognitive complaints and improve patient behavior and function in people at the stage of dementia. So in summary, for especially in this group, one should really review the medications that they're on, because that might be playing a big role in causing some of the symptoms. Improving sleep hygiene. So as I said in the beginning of the presentation, going to bed and waking up at the same time, regulate the sleep, regulate the amount of time spent in bed. don't spend too much time in bed trying to sleep if you're not sleeping. In your mind, if it's been 20 minutes or so, leave the bedroom, do something uninteresting, come back only when you're sleepy. Because if you're spending a lot of time in bed trying to sleep, your mind is getting confused that perhaps bed could be used to think about stuff or ruminate, and then you won't be able to sleep. So we have to train the mind that bed is just to sleep. Maximize your activities during the daytime. Avoid taking naps. If you have to take naps, shorten it to 15, 20 minutes. Of course, caffeine, late night caffeine should be avoided in the patients. Avoid alcohol, limit alcohol. And these things can really, really play a big role in improving the sleep of the patients, especially in dementia. So, just a few words on sundowning, and then I think I'm almost done after this. So sundowning, we hear about that, right? What exactly is that? It's a combination of confusion in the nighttime, restlessness and agitation. It occurs mostly in the evening, and sleep can play in a big role. If you're sleeping in an unfamiliar environment, if you're on sleeping pills, as I said, can impair the cognition, and if you already have underlying dementia, and if there are underlying medical problems and earlier bedtime, all this could be playing in a role in sundowning. So each individual needs to be carefully screened for these different things that might be playing in a role in causing sundowning. So in conclusion, for the whole presentation, we saw that there are changes which are occurring in the sleep architecture, and these are the physiological changes. People tend to sleep early, wake up early, deep sleep decreases, total sleep time decreases with increasing age. But decreased ability to sleep is less of a function of age per se, but there are other factors that accompany the aging that can contribute as well. The primary sleep disorders are very common. We saw insomnia is very common. We saw sleep apnea, obstructive sleep apnea is very common. And we saw restless leg syndrome is very common. We saw REM sleep behavior disorders are very common. And all of them can negatively impact the health. So regardless of the age of the patient, the sleep disorders should be treated, and because it can interfere with the quality of life, and it is associated with medical risk. With this, I would end my presentation here, and I'll just say that sleep is vital to human life. Thank you.
Are there any questions? Go ahead.
One issue that I have is it takes me longer now to adjust to jet lag when I travel across time zones, especially like Europe or Asia. How do you suggest you handle big time changes?
How to handle jet lag? Jet lag is very complicated. I would suggest that you see a sleep physician before you travel to these places. Adequate time of light exposure and melatonin plays a big role in causing and improving jet lag. So before you go, I would say talk to the sleep physician, and they could recommend which times you could take melatonin or which other times you should expose yourself to light or not expose yourself to light, and go from there. It's way more complicated than it sounds.
There's an awfully big emphasis on meds. I thought we were trying to move away from so much medication and employ other methods, such as music. There's just so many meds given to persons all the time anymore.
Right, I totally concur with you. So medications are given very commonly, and I showed you that yes, it can be given, but it should be given very cautiously. And it has their own side effect profile that it comes down to. So I think the most important thing is when you know, talking to the physician and going to the root of the problem, because oftentimes taking care of the root of the problem can take care of the whole problem. So oftentimes I always say to my patients that we are like band-aiding it with medications. So rather than band-aiding it with medications, go talk to your doctor, see what exactly is happening, and try to treat that thing.
Thank you. Any other questions?
What's your feeling about essential oils for sleeping? Do you use them?
Well, you know, there are lots of oils out there which can be given, you know, lavender oil and so forth. There are some medical studies that have been done that shows some improvement in sleep, but I think we need more data. I don't recommend it to my patients because of maybe some of the other things that may come with and the harmful effects or the side effects. So I try to refrain from the things that I don't know about and the medical literature does not back them that robustly. But certainly feel free to use it for a limited period of time, is how I would put it.
Were there any questions at the remote sites? Any more questions? All right. Well, we can thank Dr. Lilia so much